uh, Dr. Kumta and
May I now invite Dr. Samir Kumta and Dr. Anil Bhat to convene the next session, please.
Can we invite the chairpersons for this session, Dr. Avinash Mahale and Dr. Nikhil Shah? Please come on stage. Good evening, folks, and welcome everybody to the chairpersons and to my co-panelists. This session is on neglected hand injuries. A lot of people have requested for this, neglected VIC, non-unions, malunions, infected non-unions. So let's see if we can cover as much as possible in this 45-minute session. Over to the chairperson now. Mangal Parihar, you need an invitation or what? Please come.
So we'll be starting off with some interesting topics which are very commonly seen in general orthopedics and are neglected really all the way through. I had my practice in England where I didn't see much of these neglected cases. But here definitely it is a very common phenomenon even as a general orthopedic surgeon. So you don't have to be really very localized. But yeah, we'll start off with the first talk, which is Dr. Anil Bhat. And he'll be speaking on the neglected nerve injuries along with the distal transfers. So, the focus will be mainly on the VIC where the two approaches have been used. So, Anil, please come.
Thank you, Dr. Avinash. This is about the usual story in our country, which is of the VIC. When we saw this child walking into the OPD one day, 15-year-old, very scared, hand was completely covered up, parents one parent was very anxious, the other parent was not, because the other parent was the one who had taken this child to the local native bone setter. Herbal paste, bandages, goat milk, everything was done for this child, and this is how the child came in on about 11th day onwards. The controversy all of us face is whether to open this or not. Very, very difficult question at this point of time. Even if they come at 48 hours or 3 days or 5 days, always the dilemma is whether to open and decompress or not. What we did was to basically splint the child. Elevate, first 2 days were elevation and maxillary dressings, and then this is the most important message of this talk, is to get the hand into this position of safety as soon as possible. And it's called position of safety with that MCP in flexion, IP in extension, thumb in abduction. Very, very important. And my residents were on this boy right from day one. Once the skin was, we were able to touch the skin, in fact, to start mobilizing. This is my resident doing it sitting with the boy, morning and evening twice, them not the therapist but themselves, and trying to mobilize this hand as much as possible. What we need to look at is basically the disability this child would develop and what are their demands in terms of their activities after this entire thing heals. Even with this is a different child, even with the splinting and mobilization, immediate mobilization, a lot of these kids end up with this kind of disabilities. I said the dilemma was to wait, open or start doing only close management when the child comes late. But the classic dictum is to wait for about 3 months for the sequestrectomy. So I'll take you through a series of steps of how we deal with in different patients. And this 3 months is enough to save the nerves before irreversible entrapment takes place. But it's also late enough for the maturation of the muscle fibrosis. So the first common way of dealing with this when these children come is sequestration and neurolysis. So the sequestrectomy, the classic golden kind of sequestrum which people tell where we can scoop out this, is between 2 to 3 months. Very important to take out all those necrotic tissue which we call as the muscle sequestrum, so that, and look at the nerves and free them up. This is the fibrosis of both the median and ulnar nerve here. The entire sequestrum is removed, the muscle sequestrum is removed. If the child is slightly later, mild cases, when I say mild cases, this is the deep compartment which is involved. You see the FPL and you see the FDP of the index and the pronator quadratus itself. So this is the mild cases which come a little later. And this is the role, this is where your classic max page procedure helps, where the flexor pronator slide is done and the neurolysis is done with these patients. Very, very important procedure when there are mild cases. They should have good motors. Remember that when you want to do this procedure. At the end of this, you should be getting on table complete extension of all the fingers and the thumb, right? So this is very important for you to achieve on table to get the flexor pronator slide. And that's a follow-up function for that mild case here. Third option would be tendon transfer. So if your muscle sequestrectomy is completely gone and there is no muscle tissue, you have de-skeletonized all these muscles and there is motor loss, then you go in for tendon transfer. That is your third strategy. The target muscles are basically, we want the fingers to flex FDP and FPL, especially in the mild to moderate cases where the superficial and deep compartments are involved. Our donors are superficial flexors, wrist and finger extensors, and brachioradialis. Extensive fibrosis of all the flexor side structures here. After the debridement and excision and neurolysis, this is the end of that. And this child then goes for tendon transfer. You have the FCR and FDS available here. FDP is all fibrous, that's the deep compartment. It's ready for transfer here. And then we use the ECRL for FDP. And when you use the brachioradialis for the FPL. And that is the function. So third strategy is for a tendon transfer. Also, first web space we released, we give a PIA flap here for you to get the thumb out of the hand. Very, very important for you to get the thumb out of the hand there. The fourth strategy is nerve procedures for these patients. This is median nerve after neurolysis. And again, if there is a lot of scarring and fibrosis, we go for interfascicular kind of sural nerve grafting there. And this is again another case, post-fasciotomy there, poor recovery of both median and ulnar nerves, and persistent tinal sign and sural nerve grafting there. You also have to differentiate between type 1, type 2. This is Holden type 2 where there is a direct trauma here. This part is completely, intact. The classic ones are supracondylar fractures where the entire forearm compartment is, or the vascular injury, the forearm compartment is involved. Here it's not so. There is a direct compression due to a crush injury here. Absolutely no role for max page or a flexor sliding procedure here. Very, very important to differentiate this. And you need to look at the disability of this patient again for you to check what can be done. So you need to probably sometimes get distant flaps here. Complete scar extension, only the vessel was here and the nerve was remaining there. We went in for an abdominal flap for this child. This is the first abdominal flap, and then of course the tendon transfers and neurolysis came in. The thumb was still inside the palm, so the second abdominal flap there was used for the first web space here. Bony surgical procedures can be still used. Good old wrist fusion or proximal row carpectomy, the constant length phenomenon, so you want to reduce the skeletal length. So sometimes a wrist arthrodesis or a proximal row, sometimes we take just a dorsal wedge and reduce the skeletal length itself in these patients. The last strategy in these children would be a higher level of reconstruction, which is a microvascular reconstruction. So this is a 6-month-old treated child, supracondylar fracture, neurovascular injury, absolutely no median and ulnar nerve functions. We went in for a free gracilis transfer here and with sural nerve cable grafting for median nerve sensation here. So sequestrectomy, resection of the median and ulnar nerve, free muscle transfer, and which was powered by anti-intraosseous nerve proximally, and of course the vessel. So this is at 2-year follow-up, long flexor function has been restored in this child. M4 power of the gracilis, protective sensation because of the sural nerve grafting, and the child is waiting for extensor tendon reconstruction for this patient. So you have different strategies right from day 1 or day 2 when the child comes to mobilize splint to microvascular procedures. So reconstruction options range from splinting, mobilization to microvascular procedures. The only message I would like to give is, please don't give up on these patients. You can do something for these patients even if they come very late in the grotesque of deformities of these children. Thank you so much.
Thank you, Dr. Anil. That was an excellent presentation, and I hope the delegates are able to grasp so many procedures that have been done. How many in the audience have actually operated on a VIC, apart from the stalwarts sitting in the front? Not many hands going up. Oh, there are 2 at the back. Great. Okay, so we have our next speaker, Mr. Kumta. He will be enlightening us on the neglected composite tissue loss and reconstructing strategies from his perspective. Thank you.
Good evening, everybody. So, Dr. Anil Bhat has shown you what all is possible, can be done in these VIC patients if they come early, and then in later presentations also. So sometimes we have a situation where there is even extensive area of skin loss, which is replaced by a dense adherent scar. So this was a young girl who came to us nearly, Dr. Warrior actually, nearly a year after she had a closed fracture of the radius ulna, which was treated by a tight plaster, and then subsequently had complications, skin loss, necrosis, which was treated in a native place with skin grafts. So she had good elbow function, but the forearm flexor compartment was completely atrophic. It was covered with a dense adherent scar. There was no movement of the wrist or the fingers. And pronosupination also not possible. The first web was tight. The distal sensations were absent. And this was sort of function she had. Good elbow function, but actually nothing at all distally. So initial assessment is very important. Apart from a good clinical examination, you have to assess the limb vascularity, find out what the bony position is, whether the bones have united, and whether there is any infection residual or not. You need also to chart what motor function is present or what muscles are available, because you eventually have to do some kind of form of tendon transfers to motorize these hands. X-rays are useful, but we found ultrasonography by a good sonologist to be extremely useful to find out which tendons are available, where they are broken, where the scar exists, or what is the extent of the scarring, and also the position or condition of the nerves, whether they are in continuity, whether they are broken. All these things a good sonologist can point out to us. Now, what are the requirements in a patient like this? You need first and foremost to excise all this dense adherent scar and replace it with good soft tissue and skin. And at that time, you can release whatever contractures you can at that time. Eliminate infection. Try and achieve bony union and a good joint position. Then nerve repair and reconstruction if required. To motorize, you need to do tendon transfers or tendon grafting or both, or then replace with a functioning muscle transfer. Correct the bony deformities. At all stages, you need to do some physiotherapy to maintain joints. One of the pointers to eventually how good the patient is going to come to get function afterwards is the state of the hand and the state of cleanliness of the hand, you see. Especially with children, the parents are so unsure. You find the hand is dirty. You ask the mother, have you ever cleaned this hand? Because the boy is not going to clean it. So they said, no, we are too scared, it's painful, we don't know what to do. So very often these patients come with an absolutely dirty hand covered in muck. And the first thing I often do in my clinic is actually get the boy, clean the hand myself and show them that this is possible. And the moment they see, oh, the hand is clean, their attitude to the boy changes. Now, the other most important thing in this is how to sequence your repairs. So first is, of course, debridement of wounds and infection control. Then comes the excision of the dense scar and replacement with good soft tissue cover, good bony fixation, and very often, if you can do all this together with a microvascular flap, then at the same stage, you can do the nerve grafting itself. So if you have a good single stage microvascular flap, you can achieve many of the other things in that one stage. After this, because when there is dense adherent scar, whatever physio you do, the joints and the hand is not going to move. So once you replace the scar with good soft tissue, you can see the hand moving much better. And that is the time when physiotherapy really comes in useful, and splintage as well. After all this, then you can do your tendon grafting transfers or functioning muscle transfer if you don't have any available motors locally for the transfers. And then you can do minor correction, bony deformity correction, correction of the wrist position, excision of the lower end ulna or some form of to provide pronosupination, and some additional corrective procedures. So in this girl, what we did in the first stage was do a scar excision and extensor tenolysis. We resurfaced the volar aspect of the forearm entirely with a free anterolateral thigh flap. At that time, we found the fingers quite supple. When we released the flap, there was good movement at the wrist and the finger MP and IP joints. So we proceeded with the extensor carpi ulnaris to FDP transfer at the same stage using plantaris tendon grafts. And sometimes in these situations, we have had to do nerve grafting. When this girl, we found the median and ulnar nerves in continuity. All we did was an extensive neurolysis to free the nerves completely from the surrounding scar tissue. And we also did a first wave contracture release and a Z-plasty. So this is the microvascular anterolateral thigh flap in place. You look at the position of the hand, already it is looking so good, it's corrected. And the flap was well settled at the first, in the first month or so. The first wave had improved considerably. Fairly good opposition. There was good MP joint flexion, wrist extension up to neutral. So this, a good soft tissue cover and excision of scar, release of contractures achieves a lot in the first stage itself and lays the foundation for subsequent reconstruction. So this was the function after this first stage, after a session of physio. Fairly good movement and flexion in the hand. The wrist was still stiff. Pronosupination not so good. And there was still some bowing of the radius and flexion contracture of the wrist. First wave was pretty good, and finger extension was good as well. So multiple structural reconstruction can be done in one stage with nerve grafts, tendon transfers at the same time, provided you give a good flap cover. Subsequently, this girl underwent additional surgeries, correction of the radius bow with an osteotomy and a compression plate. And then a corrective osteotomy was done in the lower end of the radius to get the wrist in neutral position. So skeletal deformity correction also is important and does improve function considerably. And this is at the end of all her reconstruction. This is the position, the hand is looking practically normal. The ALT flap is well settled. And this is the function we have been able to achieve in the hand. A little bit of pronosupination, but the hand, the wrist is in mid-prone position, which is good functionally. Thumb is fairly stable, although not very mobile. But the girl is able to do her activities of daily living. She looks after the people in the house, cooks for them. And so, as you can see, multiple surgeries sum up to give a very reasonable functional hand. You have to persevere, patients have to persevere, never give up, as Dr. Anil Bhat said. And this is a video this girl sent us recently of her being able to use the hand to ride a cycle, go to school, cook at home for all the people, and she is fairly well rehabilitated after just a few surgeries. So to summarize, you have to sequence your repairs properly, get good skin and soft tissue cover, and then proceed with the bony correction and other things. And you can achieve a fair bit even in these neglected VIC hands. Thank you.
It was an excellent talk from Dr. Kumta after Anil has enlightened us on his reconstructions. So we have Dr. Mangal Parihar here, who will be speaking to us on the neglected gap non-unions and further reconstruction.
Right. So I'll show you a case of gap non-union. The main goal of this talk is for you not have to face this yourselves. This was a young mother of two, sustained what normally would be considered as a simple fracture. standard bread and butter for most orthopedic surgeons, who was treated locally. She had fever on the second post-op day, and the antibiotic was changed. She had a wound gape, and secondary suturing was done on day 5. In 2 weeks, because she was not improving, they changed the surgeon, who removed the radial plate and applied a fixator. 3 weeks later, discharge from the ulnar side also started. There also the plate was removed and a fixator was applied. A fixator was applied in the sense that, okay, some pins were put into the bone and connecting rods were there outside. I'll show you another case later on, which is where I want to draw the distinction between the application of a proper fixator and just application of wires and pins. So by early May 2000, this was the status of the bone. So the most sort of primary thing that sticks out over here is, was a debridement even done? Because if a debridement was done and the patient was stabilized, even not so well, this evolving sequestrum, the continuation of the infection, is something very difficult to explain. And that's why we always say that the scalpel is the best antibiotic. Instead of going up with more and more antibiotics, adequate debridement is what is the primary goal. So she came to us in May, by which time her pin sites were infected, forearm was inflamed, and the bone scan which she had done before she came to us showed that this middle fragment that you see over there is probably avascular. You can see a lot of lysis around all of those pins, etc. And this is, the X-ray itself tells us what's likely to happen. If you look at her left hand, the swelling, the whole limb was dystrophic, partly probably because of the infection, partly because of the instability. So we did a debridement. We put in a TENS nail. We put in a local antibiotic depot and then continued IV antibiotic as per the culture and the infectious disease. So this is what I want to highlight. That a few months of procrastination has completely damaged or completely killed that large segment of the radius, large segment of the ulna. And this is not going to contribute in terms of healing. So this has to come out. So now, from an infected radius ulnar fracture, we have landed up with a gap non-union. For gap non-unions, in the tibia, etc., in the femur, lower limb, you can do a bone transport pretty well. In the upper limb, bone transport is not such a good idea. So that's her after the debridement 48-hour wound check with stimulant inside, stabilized with a wire inside, because I didn't want a fixator out due to her dystrophy, etc. So we wanted things inside, further stabilized by a slab. That's the evolution of the wound. So when the antibiotics were stopped, her CRP was 10, and 2 weeks later, even without the antibiotic, her CRP had gone down to normal, and you can see the limb improving. That's July. August, we waited till her hand function was better, her dystrophy had gone down, and we were now left with the gap. So for this kind of a gap in the upper limb, doing a bone transport, not a good idea, because you're shifting the origins of various muscles, and that has its effect on the function of the hand. So another case treated differently with appropriate treatment early enough. This guy came to us at this point where we did debridement at all of these areas, all of the dead bone was removed, and we put in a fixator. Now, many of you all here are hand surgeons. I'm sure you all know about the JES or the UMEX fixator. I just want to point out that you can use the JES and the UMEX as a, practically speaking, as an Elizarov, as long as you have multiplanar. Don't go for those simple two-pin connectors. If you see here, there are 2 pins in each fragment in one plane. In addition to that, what you see as the blue and the purple ones, this is stabilizing another plane, and then all of that can be very well cross-connected, giving you a very, very stable frame with these thin wires, and that stability is very, very important. In this particular patient, with that stability, we were able to get rid of his infection, and he healed without doing anything. So appropriate treatment at the appropriate time. So we go back to the first case. 2 months after debridement, then because of the gap, we had to do a vascularized fibula, which was done by Samir, where they did a double-barreled fibula, and really this part of the case was all theirs. All we had to do was just put in a long plate to stabilize. So that skin was all healed, with a scar. That was replaced with a paddle for monitoring, and then a fibula placed in there. We have stabilized the middle part of that fibula with locked screws, and that's her at the end of 1 year. Yes, she has restricted pronosupination, but all things considered, she got out of this, pretty well. That's her X-rays. So the point I want to make is, for all of us in all situations, especially in the upper limb, to recognize and admit infection early. The best way, as I say, to diagnose infection is send the patient to your competitor. If that is your patient, then you will find various reasons why you want to give antibiotics, or your body is rejecting the implant, or some other BS like that. You send it to the orthopedic surgeon next door, he will recognize infection immediately as soon as he sees the patient. The scalpel is the best antibiotic. Stabilize the fracture well, as I pointed out. And today, I think infection has to be treated by a multidisciplinary team. Not only the orthopedic surgeon, but at the very least, infectious disease specialist. And then when things go out of hand, of course, other people like plastic surgery. Thank you.
Thank you very much. So we have been enlightened with so we have been enlightened with infection issues as well as the gap non-union in the bone, which I think the main thing to grasp is the vascularity has to be good before any surgery has to be carried out, along with infection control. So now next speaker would be Dr. Patankar, who will be speaking on the atrophic non-union of the radius. But before that, he would like to present this interesting case of metacarpal lengthening.
Yeah, this was a patient who presented to me after about after a crush injury of the thumb, wherein there was no place at that time where he could get a microvascular reconstruction or reimplantation done. So we had to wait for the skin to become soft and supple before we attempted a thumb procedure. The options in this, as you all know, are the best option, I would say, is a microsurgical toe transfer, which gives you a very good looking, normal looking thumb. Of course, it means taking a toe from the foot. Osteoplastic reconstruction is a multi-stage procedure. The third option also is available, that's a thumb metacarpal lengthening. After giving all these options to the patient and counseling the patient in terms of the time and the cost, the patient opted for the third option. So we did a metacarpal osteotomy and applied an external distractor in this case. And by gradual distraction, for 6 weeks, we gradually distracted and achieved this length. And then we waited for nearly a month, because what happens is that there is a lot of tissue reaction, there is a lot of internal inflammation which we have experienced with these sort of lengthenings. So we have to wait, let the periosteal tube form very well. the very important thing in the thumb metacarpal lengthening is that all of them don't wait for the natural bone formation, because even if the bone forms, it will form eventually. But one thing is that you have to take care of the pin track infections. If you have to abandon the fixator before time, then there will be a big problem. And secondly, even if the callus or the new bone forms in the gap, the callus is so weak that because of the pull or of the muscle forces acting on the thumb, it will always deform, which has been very well illustrated or documented by Yvonne Mativ. And that's why you wait for 4 to 6 weeks, let the periosteal tube form very well. You may see in the serial x-rays a thin tube forming there, and then you take a corticocancellous graft from the olecranon, a thin cortical graft which you put it in the gap. I prefer to remove one adjoining K-wire in that, as you have seen in this picture. You open up the tube, periosteal tube, you put in a cortical graft, and to have more grafts into that defect, you remove one K-wire on either side and you take more grafts there. You can achieve a slight length on the table, put in the graft and compress it. In this case, I opted even for a intramedullary pin to stabilize the graft, and then I removed the external fixator completely 4 weeks after the bone grafting. And at 6 months, you can see that the bone graft is completely consolidated, and that's at 6 months that the graft is completely healed. Now in this case, when you are doing a thumb metacarpal lengthening, you should always remember that the first web always creeps distally. So in order to, even though the length has been achieved, it is never appreciated by the patient and his relatives, or even we don't appreciate that the length is achieved unless you do a first web deepening. There are various methods of Z-plasties. In this case, we opted for the 4-flap plasty, and then that Z-plasty was done, and you can see a nicely long thumb, length of the thumb. That's 18 months post-index surgery and 12 months post-web deepening. That's the result. That's the pre-op for comparison. That's the pre-op X-ray, and that's the post-op X-ray. A comparative X-ray have been taken, which shows a nearly 50% lengthening has been achieved. In this case, the significant part or point which I want to make is there is no deformity of the graft, because a deformity of the thumb, because the graft has been maintained very well in a fixator, and a corticocancellous graft has been done in this case. So whenever you do a thumb metacarpal lengthening, first is you have to have, the patient has to be very patient. You have to be very patient. You have to counsel the patient. You have to give him all the options that are available. You ensure that the patient is compliant. The proper pin track dressings have to be done. You should remember that this is a procedure which involves multiple stages, and that means that you have to have a bone grafting and you have to do web deepening. So there are nearly 3 surgeries which every patient has to undergo, as compared to toe transfer, there is a one single surgery. Of course, osteoplastic reconstruction is 2 surgeries. So that's my presentation on thumb metacarpal lengthening. I thank you all for your attention.
Thank you very much, Dr. Patankar. So we have gone through many cases. Would the audience want any questions here, please, before we move on to the backup cases? I can see some senior surgeons here, Dr. Warrior, Dr. Lad. Any comments or any questions to be panel? Please, come to the mic.
शॉक लगा मुझे. Dr. Patankar sir, the lengthening you showed, how many days you took to lengthen that? Distraction. Because Dr. Mangal Parihar is also there. That is why I am asking.
No, in this case, you remember that this thread of this fixator is not 1 millimeter. The thread is not 1 millimeter. It is 0.7 millimeters. The thread, the pitch of this screw is 0.7. It's not 1 millimeter as compared to the Elizara, which he does. So I took 6 weeks. Initially, what happened is patient started getting a lot of pain. So I had to reduce the speed, and then again we started increasing the length. And I taught the patient only how to distract it. So we took nearly 6 weeks to get this length.
Okay. Sir, and how did you maintain the alignment in that? Because the wires you have put are accurate, perpendicular to the shaft. Sometimes I might not put the wires same way. They might go a little oblique.
No. What you have to do is
The alignment.
You touch the external fixator and use that as a jig, and put the wires through that external fixator only.
Okay. Thank you.
So that external fixator works as a jig. You touch it to the skin and then put in the K wires.
Okay. Thank you, sir.
Any other questions? Yeah, Dr. Lad.
Sir, most of these patients, they demand, they face a difficulty of wearing a prosthesis. But with this kind of metacarpal lengthening, still the stump of the proximal phalanx length remains same. And in my 2 cases experience, they were unhappy because they could not put the prosthesis still on. And I had to do a proximal phalanx stump lengthening to 0.8 centimeter, and then they could wear the prosthesis. Do you feel, was that your experience too, that the patients were happy post-op using the
patient, this patient in particular, I had given him a choice of eventually going in for a phalangeal prosthesis. But he's so happy with this length and he's using the thumb so well. In fact, yesterday only I called him up, and now he has got a job in Dubai. So that's why I could not send the recent X-rays and the post-op this thing. I learned that from his brother that he's in Dubai. At present, he has got a job with this thumb. So good for him.
Thank you, sir.
Yes, Dr. Bhatia.
On the technical point, when you lengthen the first metacarpal, the abductor pollicis brevis and the adductor pollicis are both MP joint flexors. I put it to you that lengthening the metacarpal led to concomitant shortening across the MP joint that produced a flexion of your proximal phalanx, which is clearly seen in all your photographs. And the eventual length of the thumb that you achieved appeared shorter because your MP joint was permanently flexed. Had you transfixed the joint during lengthening, perhaps this problem could have been eliminated because your EPB would have kept the MP joint straight.
Yeah, I agree with you. That's a problem which we face in most of the patients. This patient fortunately was so cooperative. I told him that this is a possibility and you have to keep on moving your MP joint. You have to keep on moving whatever that stump is available. You have to keep on moving it, and he moved it so well. He still got a very, very mobile joint. In fact, in other cases also, I have transfixed that MP joint with a K wire. Otherwise, the whole thing bends so terribly that all the purpose of this lengthening is lost. I completely agree with you, and it is a very important point that you have made. And I think the audience should take note of this.
Thank you, Dr. Bhatia. Dr. Kumta.
So if nobody has questions, a few comments to make. One is, as you can see, most of the cases that we showed, either Dr. Mangal or Dr. Anil Bhat or me, that these are difficult, challenging cases where you need a multi-specialty approach. And, it's not, even if it's a multi-specialty approach, it's not like a game of table tennis. Hit one shot, then the other specialty, the other, then and fro. Like in ancient Indian drama principles, for every drama there used to be what was called a storyteller or a sutradhar. So all such cases need a sutradhar. In most of my cases, I had the benefit of Dr. Warrior being the sutradhar. He calls the shots. He decides what is the sequencing, when it is done. We discuss. For most of the cases, it's never that I do mine and he is away doing something else. We are there always together. That is why we can get such good results. This is, I think, one of the drive home points for this, for this session. The other, a few comments on the case that Dr. Mangal showed, where we had to do double barrel fib. So for those who are not aware, you have to actually give a U-turn in the fibula by removing a central segment so that the pedicle forms a nice U without any compression or kink. In the forearm, because both bones were not united, there was a gap. It's not so easy to slot both radius and ulna in with those segments of the fibula. We had quite a bit of difficulty, and that was shown, or the evidence for that is the fact that because of the difficulty in slotting those bones in, having space for the pedicle in between radius and ulna, and in between all the muscles and tendons on the dorsal and volar aspect of the forearm, he did have some partial necrosis of the skin island. So, although we had partial necrosis of the skin island, even most of it survived, but the bone survived and united. So, it's not easy to create a lot more space than you think, because the fibula comes with its soft tissue, with the pedicle, and you have to ensure that there is no compression there.
Thank you. I had one question for Dr. Anil. You mentioned about taking all the dead bone out, the sequestra, etc. So pre-operatively, are you doing scans or anything, or it is just an intraoperative decision in your staged VIC release?
No, I mean, basically we go by X-rays and then we go intra-op. There's no scans involved in these, definitely, yes.
One point to what you said about debridement of bone. And this is my common message to everybody in meetings or when showing such cases, especially to orthopedic surgeons: don't fall in love with loose bone. That the fact that loose bone with periosteum is vascular is all. Yes, you have to throw it out of the window.
Yeah, Dr. Mangal
so
also
most
made
of
the
these
same
small
point,
bone fragments are going to die. So when we do flaps and cover, invariably find that one small loose fragment has got infected. Unfortunately, the infection discharges distally, beyond your flap. So the skin necrosis is beyond the flap, and then your flap is inadequate because you do not anticipate that. So if I do a case with Dr. Mangal, I know that he's going to take out all the dead bone and more. Then I know that whatever, if I have to put a fibula, I know that there is no infection on dead bone around.
Thank you, Doctor.
So I have a saying for that. Plastic surgeons hide the sins of orthopedic surgeons.
Yeah, that's a nice one.
No, the question has just struck me. If in a resource poor situation where I don't have the services of a microsurgeon or an expert external fixator person like Mangal, and suppose we decide to get the shortening, let the forearm shorten, will it make a difference in the function? Will it be better in a resource poor situation? Because what they have achieved is they have given us the complete length of the forearm by doing flaps and fibula and all that.
So, our experience with reimplantations, and this has been published by the Ganga Hospital group as well, that shortening does not reduce the function one single bit. So if you need to get bones to unite, you need to shorten to do that, by all means go ahead and shorten. Shortening will not affect the eventual. As much as possible. No, there's no limit. As much as possible. You can shorten, get the bones to unite without infection. Everything else can be done later.
Is there a difference? I mean, you gave the example of replant. So is there a difference between an arm shortening versus a forearm shortening? For me, forearm shortening is more disruptive than arm shortening when you have a humeral shortening for replant.
Correct. So you can, if you have to shorten the forearm, what counter? If you don't shorten, you have to put in bone grafts. And you may not get end-to-end tendon repair or muscle repair because there is loss there also. So eventually, you don't shorten, you try and get bony unit grafts, and eventually you'll end up with, if you shorten, you get very often end. the structure.
So,
One-
in your
one-
case, with
yeah.
without the vascularized fibula, is there an option for a one-bone forearm with the amount of segments we have with a short graft in between?
Yeah, that's why I said, what are your opinions? One of the things I want to point out in terms of what you have said, Samir, is in replants, you will do almost equivalent shortening of the bone as well as the soft tissues. Here, you will have relative lengthening of the soft tissues, and therefore function definitely can be affected. So there, something like what he is saying, where just reduce your gap, which will be amenable to a corticocancellous graft
from
or
the
something like
iliac
that.
In the case Dr. Mangal showed, there was extensive infection, so quite a bit of dead bone. And it started off as a closed injury, so there was hardly any soft tissue damage. So in such situation, it's better to replace the bone without shortening or with minimal shortening and not try and do shortening. Have functional depth. So I'll put the same question to Mangal. Did we at that time consider shortening and getting end-to-end union? This is not feasible.
That part, not only not feasible, partly we knew that, okay, this is available to us. But the other thing I must point out is the definition of resource poor is becoming, when we started work, we were one of the few guys who were doing microvascular. Today, most largish cities have got decent, exposure to plastic surgery. So that also, I think, has changed.
Any more questions? Dr. Warrior, would you want to make any closure comments?
They're asking the Sutradhar for the final comments, Dr. Warrior.
No final comments, just that the reason that you take out the middle segment of the fibula is not just so that the vessel doesn't kink, it's also to maintain the interosseous membrane so that pronosupination can be retained. That's an important thing. Double barrel fibula, that's a very rare surgery for forearm defects, for radius and ulnar defects.
Okay, so thank you audience for being there. Where eagles dare. I hope the take home message is that be careful when you operate on that. Thank you. Thanks the team.